can really refer to Carl Hansen Søn as a living brand. It can be your home, it can be about friends and family, it can be about work and play and entertainment. Our pieces transcend from one place to another.
Carl Hansen Søn is a Danish furniture manufacturer that is third generation and family owned. We really pride ourselves on passionate craftsmanship that's really felt throughout the entire brand and all of the products within our collection.
In our New York showroom, you can get a sense of feeling of how it would be to live in this space. In fact, many people come here and want to live in our space.
When you come into our New York flagship store, you'll be able to see a number of classic designs, the iconic wishbone chair, for example, as well as some of the first 5 masterpieces that have been in production since the 50s.
We've also created some areas and vignettes to give you that whole sense of the experience. The natural materials, the craftsmanship, the design that has gone into these pieces over the years, and the classics that are so relevant still today. There's such a wide array, there's a little bit of something for every space. And the interesting thing is that they all fit together so nicely.
In addition to these Danish classics, we also work with contemporary designers. Rikke Frost is a contemporary female designer, and this year we launched the sideways sofa. And what's really great about the piece is it's designed in a way to promote conversation. So the curvature actually makes it comfortable for 2 people to sit across from each other and have a conversation. And what's great about these pieces is, although they're contemporary designs, they fit seamlessly with our entire collection.
Having the old and new designers together create this continuity that brings a rich history forward.
I think in terms of our product, there is a really beautiful sculptural element that is to be admired. And because our products are crafted with such high quality materials, they are everlasting and can be passed down from generation to generation.
Hi, everyone. Thank you for joining us for Developing Communities for Better Health Access with HDR. I'm Tina Brennan, Vice President of Marketing and Events for Metropolis. This is the 7th year for Think Tank Series. It's a thought leadership program that visits top firms in key markets in North America. In February, we were in Atlanta. In April, Chicago. In May, we visited hot markets of Austin, Minneapolis, and Denver. And in July, we were in San Francisco. Today, we are very pleased to be hosted by HDR in New York, who will be discussing the direction and dynamics of new health and mobility paradigm in the planning and development of our cities. The next week, we'll be visiting the New York office of Perkins & Will. And we hope you will join us for another thought-provoking discussion. The registration URL will be found in chat. The discussion from today's panel will be recorded and aired on DesignTV by SANDOW, and then available for viewing on demand on Metropolis's website. Today's panel is CEU accredited through AIA IDCEC. If you do not request accreditation when you registered, please send an email to webinars@metropolismag.com. The URL can also be found in chat. We will not be using the raised hand or chat function today for questions or comments to the moderator or panelist, but we do encourage questions through the Q&A feature. Also, please note that there is an upvote where you can pick the questions that you would like to see answered first. Hosting an event like this requires the support of great firms like HDR and our incredible sponsors. We like to thank Arcom, Woven by Imagination, Ardent Studio, high-performance glass solutions that inspire great ideas, engage collective thinking, and elevate every space. Growy, designing and engineering innovative water products for bathroom solutions and kitchen fittings. LX Houses, creating human-friendly, eco-conscious spaces by offering innovative premium quality surfacing and flooring solutions. And Versteel, a solutions provider of American-made furnishings for working and learning environments. Today's panel discussion will last approximately an hour and a half. And now I would like to introduce today's moderator, Metropolis's editor-in-chief, Avi Rajagopal. Avi?
Thank you so much, Tina. And thanks everyone for joining us today. You know, there's no better time to talk about access to health than during one of the worst health crises of recent memory. One of the things that the pandemic has really put into focus is just how critical the equitable or equal distribution of access to health is. It has been a key indicator in how communities have fared during these past several months. However, access to health has not always been a central concern of how we design communities, whether they be urban communities, rural communities, or those in between. It has not necessarily been the framework within which we think about how our built environment is shaped. But hopefully that is set to change. And we're going to talk a little bit about that today with our amazing group of panelists. We have with us today Randy Howard, who is the SVP of Corporate Facility Services at Northwell Health, which is New York State's largest healthcare provider and private employer. In his role, Randy oversees the design and construction of all capital improvements for Northwell's 10 million square foot physical plant. Randy also oversees all finance and operating activities associated with the health system's nearly 7 million square foot off-campus portfolio. Randy, it's such a pleasure to have you with us today.
Thanks for having me, Avi. It's a pleasure to be here.
Also with us is Peter Youngkunst, who is Assistant Vice President Facilities for Emblem Health, a health and wellness company that provides insurance plans, primary and specialty healthcare, and wellness solutions. It is one of the nation's largest not-for-profit health insurers, and it serves more than 3 million people in the New York tri-state area. Peter, thank you for joining us.
Thanks for having me. It's nice to be here with the panelists and everyone else.
Also on the panel today is Fabio Tiers, who's founder and CEO of Ponto Care Incorporated. Ponto Care prevents the evolution of chronic disease complications by utilizing a smart mobile exam infrastructure that recreates and staffs the exam room wherever the patient chooses to be, using the same protocols, equipment, and staff employed in clinics, while ensuring that the experience is seamless, safe, and cost-efficient. Fabio, it's such a pleasure to have you.
Really a pleasure to be part of this panel.
Also with us is Farzana Gandhi, founder of Farzana Gandhi Design Studio and Associate Professor of Architecture at New York Institute of Technology. This year, Farzana also co-founded the Collective Infrastructures, a multidisciplinary design lab confronting complex societal challenges with a unique comprehensive response. Her current projects include grant-based humanitarian work and pro bono efforts. Farzana, thank you so much for joining us.
Thank you, Avi. Thank you to HDR and Metropolis for the invitation and to join such esteemed speakers in this conversation. Thank you.
And of course, our hosts for today, we have Daniel Cusick, who is the health principal at HDR, with over 30 years of achievement and progression in leadership, design, and execution roles. Dan has a long history working for various healthcare systems in New York, specifically on Long Island. Daniel, such a pleasure to have your wide perspective on this topic.
Thank you, Avi. It's very grateful for everybody to be here and for letting HDR host this. So thank you.
Randy, I'm going to start with you. Northwell, has this large network, and you serve so many diverse populations across New York State. And your patients come to you in so many different ways, across distances. They come by private transit, public transit, now telemedicine. Can you talk a little bit about how you ensure or work towards a consistent patient experience across all of those modalities?
Absolutely, Avi, and it's a real critical component of everything we do. And starting from the very beginning, we really infuse a sense of systemness through the entire enterprise. While every site is unique and has their own set of diversity, we still all carry the systemness of Northwell Health and the values that we espouse through Northwell Health as well. And when I say the very beginnings, ironically, we have our orientation program is called Beginnings. And at Beginnings, the first speaker is our president and CEO, Michael Dowling. He makes it to each and every Monday. Every Monday we have this Beginnings to really personally see every new employee and share with them his philosophy as an immigrant from Ireland, and the hardships that he endured both in Ireland and when he came over to the United States, and how healthcare has been a major force shaping who he is today. So we're able to really start at the beginning with Michael Dowling infusing that systemness and sharing our values. And then as the teams go out and work in their locations, they're guided by a set of lengthy but very understandable principles, right? So we apply a consistent standard of care by specialty in everything we do, which is all really founded in evidence-based research. So whatever the evidence-based research data supports as a best practice in healthcare, all of our hospitals, all of our hundreds of ambulatory sites all adhere to that, and also go through very open and very upfront peer reviews, ongoing focused professional provider reviews or focused professional provider reviews to ensure that we are adhering to and exceeding healthcare standards throughout. And again, that would apply to both coming in a traditional model, whether it's going to your doctor's office or a hospital. And as you mentioned, Avi, telemedicine as well, because COVID has really accelerated the acceptance of telemedicine, but we still have to follow best practices, evidence-based practices as well to make sure our patients have that same type of care. And that really gets into the specifics of the clinical acumen that for the folks that are part of Northwell, and very well trained, very, very well educated people. But getting back to a little bit more of the values, all of us are infused with patient and family-centered training and focus, right? Everything revolves around the patient. It's not the old model from a few decades ago where everything revolved around the physician. We all put the patient and his or her family, right? An important member of the healthcare team up on that pedestal and ask, how are we doing and what else can we do? And really listening to what their needs and concerns are, and more importantly, their fears, right? And even as good as we think we are, no one wakes up in the morning wanting to come into a hospital or wanting to go see a physician, right? They'd rather do something much more entertaining than that. So we really provide a lot of focus on that patient and family centered care, and really monitor our patient experience and family experience scores as well to help improve ourselves. Every day there's an opportunity for improvement for how we applied our clinical prowess as well as our interactions with the patient and family nucleus as well. And we also evaluate ourselves through Medicare or Medicaid's value-based purchasing, right? How well are we meeting all of those metrics, whether it be morbidity, mortality, use of imaging, efficiencies, how pleased overall people were with the services they received. So, and we don't use it as one data point. We use them as several data points in our ongoing search for excellence, right? We always strive for excellence by continuing to have a focused PDCA approach, plan, do, check, act, and continue to improve those processes all the way around. So we put all those in together to really develop a standard approach so people are receiving same types of care throughout the enterprise. And from a physical plant perspective, we also employ standards of design so that our hospitals and our ambulatory sites have some similarities. They don't look identical, but our logo is prominent everywhere. Different design patterns are very prominent as well, so that you get the sense of, yes, this is a Northwell site, and here's what I experienced last time, and so I expect to experience that same great type of care as well. So we wrap those all up together to help provide world-class care throughout the enterprise.
Thank you so much for that, Randy. I mean, I think there's so much to unpack in what you said, but for the architects and designers who are listening in today, I think there's just a few things that I'd love to emphasize. I mean, I think first of all, that point of contact, right, with somebody who's come in for care or who's accessing care through telemedicine or in other forms. And so, that experience is sort of at the nucleus of everything that you're talking about, right? That's right at the core of that. But supporting that is this beautiful thing that you brought up called systemness, right? Just this understanding that, when you come in for care within a healthcare system, do you have a sense of, from a patient's point of view, do you have a sense of sort of how the system works for you, right? And I think that sometimes can be really complicated. So healthcare spaces that articulate that are just so successful, right? And then, of course, you brought up the various ways in which you maintain, the quality of care, the consistency of the patient experience, whether it's through your own internal practices, through the data metrics that you track, as well as your standards of design. And I think, that's really important because that's what then contributes to that systemness and then makes that individual point of contact good, valuable, and a pleasant experience. So thank you so much for that, Randy.
Oh, you bet. And I just want to add to that when you mentioned the standards of design, because, right, it's really, people evaluate us on the aesthetics, right? You think of quality when you see a clean, pleasing appearance. People have determined their quality level of your site before they see the first provider. So everything about the parking and the physical plant really contribute to that decision before they see a doctor or a nurse.
Okay. Absolutely. And I wonder how those standards of design will develop in in virtual situations and telemedicine situations. Would be a Fabio to talk to us about that in a few minutes. Just to our audience, everyone, we are taking questions at any point during today's discussion. So if you hear something that sparks an idea in your head, don't let it escape into the ether, put it down into Q&A and allow us to address it. We're here to talk to you today. Peter, I want to bring you in next. Can you talk a little bit about Emblem's neighborhood care program? So, Randy talked to us about the healthcare system itself. And now, to zoom a little out of that and talk about the connections between that system and the community. And I think the neighborhood care, really does improve access and, influences how people use the healthcare that is available to them. So do you want to talk about that, Peter?
Sure, thank you. Yeah, we really think the neighborhood care spaces are special, right? They're co-located within our medical offices. There are 14 of them. And I think, if I understand, Randy talked a little bit about the company culture and also about the built environment. And, you know, we like to think that we're providing, you know, competent, culturally oriented care. And that's what those care officers do. And they're sort of even specific to the neighborhood they're in. So if you're at the one in Harlem, you know, you're going to find people that live and work in Harlem working there. And if you go to the one in Chinatown, you'll find, you know, it also has, you know, people who speak those languages, right? And it's a place that you can walk in, you know, unlike maybe seeing a doctor, you don't need an appointment. You're made to feel welcome. And, you know, they can actually connect you, you know, to an appointment to your doctor. They also can speak to you about other benefits that are available within your community, other programs. It's also open to members and non-members. So if you think about that, you know, it's not just the 3 million plus members that we think our door is open to, but it's open to everybody. And you can come in, you can sit down, you can have a refreshment. And I think, you know, there's a sense of, you know, inclusiveness to having something like that co-located right next to the medical office space. And we started, I think, with 3 of them, and now we're up to 14. And it's part of our, you know, our programming. For those of you that are coming from the design and architecture background, you know, you would maybe question, like, why are we having a few thousand square feet of space for that kind of activity right based within your medical office space? So we're really proud about that, and we think it's something that we're going to, you know, continue to build on that.
You know, I love that. I mean, I think it's such an interesting program to help weave in your services sort of into particular communities and kind of create those, you know, sort of much stronger, almost fingers into the community, open up the doors a little bit more. And I think that's interesting, you know, with you know, a large healthcare system at its core, what are those interfaces, you know, with the community, and what do those points of interface look like? Thank you so much for that, Peter. Fabio, I'd love to talk to you about a different modality of interfacing with people, you know, which is what PontoCare is working on. Tell us a little bit about what you do, and, you know, how it improves access, but also what some of the challenges you face in terms of folks being able to adopt, you know, a telemedicine or a digital or virtual sort of care situation.
Thanks, Avi. So the key value proposition for PontoCare is to improve access, which is core to the conversation today. And we are small. We're not, I mean, the other side of the spectrum from Northwell and Emblem, but our vision, our mission is to focus on helping patients specifically that have a chronic condition, that have to go to the doctor very often to monitor their chronic condition, being a chronic kidney disease, chronic heart failure, diabetic retinopathy, glaucoma, those diseases that need care frequently. Every 2 months, every 3 months, the patient has to go to the clinic. Of course, that gets old. That gets old for the patient, gets old for the caregiver, and lo and behold, the patients stop going or are not compliant, and the disease complicates, and then it's very bad for the patient, but it's also very bad for the system and the healthcare costs. So we are very focused on improving that by doing the following. We for these patients that are going to the doctors often, we do the pieces that need to be done physically at the patient's home. For example, oftentimes there's a need for ultrasound, there's a need for blood draw, something that, or like eye exam. Those things, to the extent that it's possible to do, to bring the equipment and to be the diagnostics and using technology to make this compliant and fully comparable to the clinic. We do that in the patient's home, collect the data, and enable this doctor to do a full consultation without cutting corners. That would be through telemedicine. So in other words, if you look at it from the other way around, we are expanding the scope of virtual care, we're expanding the scope of telemedicine consultations. And by doing that, we are making it much easier for these patients to stay compliant with the regimen of medical evaluations, and to stay compliant with the relationship with the doctor. So one thing that's key about Ponto Care is that we are not a new company that's doing telemedicine. We're always supporting telemedicine, existing organization like Northwell and Emblem, any of these organizations that have a need to serve the patients. We are there to do the exams, pretty much like, and we are limited to that. So that's something that's core. So in terms of the challenges, we are facing the challenge, of course, for being new. I mean, there's a big aspect about reimbursement. I'm not going to get too much into that, but it's a new structure, and then we need to work the things out with the health plans, and that's really being not really much of a technology challenge, but really a structural and legacy, dealing with legacy system challenge. And I think it is something that can be worked out, especially in this context, again, not only of management of patients with chronic diseases, but in the context specifically of value-based care. Because if there's an incentive that's intrinsic to the payment system that entails improvement of key metrics like reduction of hospitalization, improvement of patient outcomes or mortality, morbidity, I think this is the kind of thing that a better access through a system like Ponto Care in conjunction with the existing health provider, it makes sense. Let me stop here.
I think what's so interesting about what you're talking about is is kind of layering, is really strengthening telemedicine as an option for many communities, right? And as you said, it comes with so many challenges. But it just adds another kind of, I think, dimension to how distributed healthcare is becoming, right? And or needs to become, and some of the challenges that are still there in providing that kind of distributed care to people, regardless of where they might be or what their access to technology and other things might be. But ultimately, I think the goal is, we have to work around those systems to make sure that that people have the access to care that they need, that that they don't fall non-compliant, and then that it doesn't start to affect their health. Farzana, can we turn this around for a second? We've been talking mainly from the point of view of the goals of a health organization, in terms of keeping people healthy or reaching people or ensuring a good experience and so on. What if we were to turn that around and talk about health from a community's point of view? What do communities care about in the way their cities or towns or neighborhoods are designed, and the way that healthcare facilities are integrated into, where they live and what they have access to? So can you talk a little bit about that from an urban or community point of view?
Yeah, sure, Avi. Thanks for the question. So maybe to give a little bit of context, my practice and research really is committed to open, collaborative, inclusive design processes. And so, while the work spans in scale from urban scale to building to placemaker to product, really, there's a commitment to a level of outreach that's consistent in all of the work. And so I find myself really working hand in hand with climate and socially disadvantaged communities all around the world, in Africa and India and Puerto Rico, but also right here in our backyard New York, in Bushwick, the South Bronx, Bed-Stuy, Inwood. And, in kind of having these conversations, these messy conversations that occur in schools and in churches and public gardens, where you really try to listen to the community and you invite them to share their voice and their concerns. And, you kind of have them document observations through messy exercises. What really comes out over and over again is that health is a huge part of, quality of life and a lot of the concerns that communities face. And I would say that from a community's point of view, the question of healthcare access is probably threefold. There are three components. One being physical access, the second being the quality of access, and the third, more sort of non-physical barriers to that access. And I think Peter and Fabio started to touch on some of those things. But in terms of physical access, it's yes, it's the ability to hop on a subway or a bus or public transit and have that available to you within 5 or 10 minutes of walking from your residence. And have that go to a station or a stop where there is a medical facility of some stature, right? As Fabio's pointing out, that's changing, right? Now we have also telemedicine and mobile systems, right? In Puerto Rico, where that's not possible, where you don't have, sort of transit systems and physical access, right? I'm working on sort of decentralized infrastructure systems, right? That start to micro infrastructuralize, if that's a word, the systems of healthcare and energy and water and so on. But I think the idea of the new sort of 5-minute walking city is current. It's being talked about in Europe post-pandemic, right? The idea to have all of the resources and facilities that you need to have quality of life within 5 minutes of walking is something that, I think is talked about quite a bit as we start to rethink our streets, our urban spaces, and they may actually also be sort of solutions to delayed response times from EMS workers, right? Like there are communities where you call 911 and, the EMS does not arrive as quickly as in other communities due to traffic or longer distance or less availability, and so on. When it comes to quality of access, it's sort of a given that higher quality medical providers, typically live in and work in higher income neighborhoods, right? I think, Peter's idea of sort of this neighborhood care system is a start to address that, where you do bring providers to the communities themselves, right? I think location proximity, I think, a lot of facilities have closed and budget cuts have happened due to economic crises and even now with the pandemic, there are facilities that just don't compare in the quality, right? There are less ICU beds available, less specialists available, and there's a lot of technology and data out there, right? And there's data that tells us all of these things. Mainly it's statistical data. Oftentimes it's not qualitative data that we collect from the community. I'm working at the moment also on a new digital interface that starts to bridge that gap, right? To kind of bring, find ways that community can participate in data collection in a sufficient way that it can sort of offer, specialists and the professionals in the room ideas about where those gaps are in all of New York City, right? I think there's a lot of ways that we can leverage new technologies and so on. And then on the non-physical barriers to that access, right? We often don't talk about the fact that although resources may be available, there's a lot of lack of awareness. There's lack of trust, right? There's also fear of discrimination, fear of stigmas associated with certain health conditions. Of course, Peter mentioned language barriers, sort of paperwork barriers of getting into the system, right? And I think there's a lot of much needed outreach and on the ground field work and partnerships with local community groups, right? Trusted sort of mutual aid groups, trusted advocacy nonprofits and churches that people know and have large constituent populations that are following those groups. And those partnerships can really start to bridge the education gap, right? And the ability to, or cultural gap for that matter, and the ability for sort of formal healthcare systems to become part of the everyday in neighborhoods where predominantly non-formal systems exist, right? And not to disengage with the non-formal systems, right? And there's a lot of holistic practices and wellness and health and awareness ideas, meditation, yoga, so on, that's sort of surfaced in the last couple of years, right? And there's really a disconnect, I think, between formal healthcare and informal healthcare. And how can we start to tailor our care per neighborhood and sort of the cultural differences that may exist, or the real kind of challenges, the health challenges that a certain community might be facing is something I think that's worth thinking about. So.
Thank you so much for that. I think that was a great, you structured that, the sort of the three ways that we can think about access. And I think that's really important. And, as you were talking, I think it's been incredible if we think about our experience of the last year and a half, how all three failures in access have played into sort of the health situation that we find ourselves in. And of course, the one that seems to be most intractable now is, of course, cultural positions and awareness around healthcare issues, especially when it comes to the COVID-19 pandemic. And so, I think start radiating out from there, just the various barriers to access that we need to address. And I especially, want to emphasize your last point, thinking about healthcare systems or health systems or even health in a holistic way, and thinking about sort of almost every tool in the toolbox, right? Everything that will help. And certainly in certain communities in New York City, the city has taken that approach, through various programs. But there are so many determinants to health, and then health in turn determines so many other sort of factors for communities in terms of education or wealth generation and all of those things. So, we are only now waking to the fact that this question of access to health is such a central question as we look at patterns of development, whether it's commercial or residential development, as we look at patterns of how communities are being designed. So I want to bring Daniel in on that, because I think that's the thing here, in terms of when you think about designing communities around this notion of healthy living, at various income points. I mean, I think certainly at the high end, with certain communities, as Farzana pointed out, it's kind of understood that health is such a key part of the urban design equation. And in some others, it doesn't tend to be top of mind in the conversation. But as we think about health-oriented developments and communities that are designed around health, how do we partner on that? Who should designers be working with? Who are all the folks? And Farzana mentioned some, Fabio mentioned some, and we have some models from Randy and Peter too. But if you could talk to us about sort of the availability of different partners and expertise in kind of bringing those design projects to life, that would be great.
So thanks, Avi. Appreciate the question. Very detailed, deep deck on the answers. But, before I get there, I think I want to start is at some time in history, architects have been given this kind of baton of being these guardians of building, the foundations in society and like all these composites. And architects took it on. They were just building a building to now, we curb societies and so forth. So for HDR and like myself, the way we look, investigate, and design too, we look at more of an arc story and an arc meaning to it. And what I mean by that is we look at healthcare even the same way, where it's really cradle to grave. So with that, health is a given thing to every single one of us right at birth, right? So nobody should have less of Unfortunately, the world has been curved and molded different ways. So again, going back to the architect being this person who has this mic in their hand to talk about it and curb. We at HCR do a little bit of this aspect where we preview, review, and endorse. And what that basically means is we gather a lot of information. We go out to a lot of parties, regardless of size of projects, right? We're very lucky to have projects that are components to relationships with healthcare systems and so forth. But then we have large projects. To that point, we go back and take a step back and see where we can use those developments to the better good of education. A lot of it's been spoken already, but it's education, whether it's even from the higher ed or even to the point of individuals on like the panel here and so forth, writing white papers and still educating public. It's health systems writing out informative papers and so forth. It is to urban renewal on community boards as well as developers. It is with developers is a large aspect because in America you can just buy property and basically in certain zoning do what you would like and so on. But if we can get with developers to work in conjunction with health systems that have a reflection to the community's needs, that us as architects and designers, we now use data. I love the comment about stagnant to qualitative. HCR is now actually using an amazing amount of qualitative because it is there, the data, and we use computational analytics to put that together to help make smarter decisions and then govern. Well, I can't say govern because architects, we don't actually pay for these developments, but we can help guide the power brokers who are politicians, again, commissioners of urban renewal, city planners, administrators, and facility directors at health systems to make these thoughts and decisions about what's best happening in real time in their societies. Neighborhoods build communities, right? So we are now to the point of being able to pinpoint within zip codes and so forth, through data, some of the reflections of what's happening in real health in those communities. And unfortunately, incomes and so forth reflect to that. And then we do the best advisement possible to clients and health systems to bring that across. We are finding a lot of health systems are starting to conglomerate and bring themselves and purchase together, which is even a better mission statement that we can actually work with across the country and actually for us internationally. It's a joy working in this field. One, I do it for myself. We do all talk about health as if it was something for somebody else. Unfortunately, this is a one-way street for everybody. So we tend to stop and design for ourselves. Who and how would we be in these environments and or neighborhoods and communities, and then pull ourselves a little bit back for our families and so forth. So with that, we actually want to explore the communication much further. And we talk about accessibility. If you say to a technical architect, you're talking about the curb on the New York City, right? To get up on Americans with Disabilities Act. We can take it that granular, but I think we as a nation right now should be looking at accessibility, especially this trigger moment that happened in history, this pandemic, where are we actually able to reach every single individual with a common care, whether it is on telemedicine, whether it's communication, whether it's on the experience or the brand you trust. If it is urban renewal, which helps with like the mayors and the city planners to get to facilities better and make better decisions, that is where we are looking, and we actually have been doing, as well as intertwining it with networks on transportation of rail, highway, and then secondary roads. And the worst part is actually parking. And we say it because if you don't have the right parking, people, they go to the next shop, and it's absolutely brutal. So we're A through Z in our developments and thinking and our conversations with all the players to be. And the one voice that is not spoken enough is actually the person we're caring for, the person at home. And they don't have a voice. And we've got to find out a way to get access to their voice, to what they really need the most. And unfortunately, we are looking at, again, data from the outside in a qualitative way to kind of help fill that gap. So it's an organic model. There's nothing perfect about it. Yet we are trying at exponential speed. Pandemic taught us one great thing: this stuff changes immediately, and what can we do to react? Because at the end of the day, every single person on this has family or even themselves who wants good health. And it should be nothing more than something we are actually able to get. So a little bit of a long-winded answer there. So I don't know if that helps, but that's where we're engrossed.
Health is really everything, and health is everywhere. I think, Daniel, that's kind of what you've emphasized for us here, because when you think about it, like you brought it right back out to the larger mission for architects and interior designers in general, right? Well, how do we shape the design environment to improve people's lives? And within that, I mean, health is such a critical and key component, and so designing for health goes well beyond designing healthcare spaces or healthcare facilities or even healthcare systems, right? And so how do we start to kind of take on that task, as you said, which is huge. You also spoke about the inputs that we need in order to carry out that design task, and how those inputs are changing, and also the voices that maybe that we haven't been paying attention to that much. And I think that's a key challenge that I'd love to kind of talk to all our panelists about as well, is, how do we gather information? How do we kind of bring those perspectives in? I have a question for our panelists here, but before I jump into our next idea, a quick thank you to everyone on the panel for talking to us today. A quick thank you to HDR for hosting today's discussion, and a thank you to Arcom, Arden Studio, Crowe, LX Houses, and Versteel for making today's discussion possible. And to everyone who's listening, thank you for joining us today. A quick reminder that we are taking questions for this panel. So if you want to put any thoughts, comments, questions, suggestions, anything at all into the Q&A, we'd love to see those. There's a couple of questions in here already that we're going to take in a few minutes. A special reminder to the interior designers in our audience today, whether you work on healthcare spaces or not, just this week, Metropolis was part of the launch of an interior design pledge for positive impact, which pledges interior designers to recognize the influence that they can have on climate, health, and equity, and suggests a common framework, the first we've had really for sustainable interiors and resilient interiors, a pledge that's been framed by all three professional associations in North America and by Metropolis. So I do hope you will read the pledge and consider signing it and committing to making an impact on people's health, as well as on the climate and on equity. So with that small segue into a question for all our panelists, and I'm going to let Daniel off the hook on this one for just a minute. But Fabio, Peter, Randy, and Prasanna, can you talk a little bit more about how you currently do or hope to use designers or design methodologies in the work that you're doing? What are you looking at design to help solve within this larger question of access to healthcare? I know it's a really big question, but it would be great, since our audience is mainly a design-oriented audience, for them to hear what are some of the challenges that are out there for them.
Who wants to go first?
I can start quickly. I'm here at New Lab. New Lab is a place where there's a focus on industrial design and innovation. And I came here exactly for that reason, because I needed to work with designers, experienced designers, in industrial designers to build the equipment, the mobile systems that can enable us to get into the house of the patient and out quickly while doing everything using the same equivalent system that are there in a regular clinic. So it involves system thinking, and involves a kind of the mechanics of that are similar to what you have in a regular clinic, meaning that we have to optimize for time. At the end of the day, we have X many hours in the day, and we need to utilize those assets as frequently as possible. Meanwhile, we have to give like the patients a wonderful experience. And so it is everything has to be designed to the T. I mean, the words that are said, how it's explained, how it's set up, how it's wrapped up, everything has to be so thought out, because every minute counts.
So I would say that it's really important to us. I'm coming from a design and construction background, a facilities background, a real estate background. There's always a lot of transactions. You meet with so many different people, right? So you meet with, administrators, operations people, clinical managers, doctors. I like going to our offices, and sometimes just even sitting around with patients coming in and talking to them a little bit, right? And then I think about the role of interior designers, and it could be, again, kind of traditional, right? We engaged a large healthcare design firm to give us a guidelines, and it's over 200 pages. So, it has furniture, it has finishes, it has lighting, it has all those things that we think of as interior designers that we need them for. And but then I think about what I like about interior designers is sometimes when somebody stops thinking about all those little pieces and they walk into our offices and they actually, they're kind of struck. They're like, well, there's a really nice ceiling height here. There's a lot, I can see out a window, the light is very nice. Oh, look, the height of that chair is actually comfortable for me to sit in and get out of. We even have sort of changed our artwork, Farzana talked about partnerships, right? So we found a partner is a woman who was finding artists and communities with challenges of their own. It could be disabilities, homelessness, and so on. And so we actually, when you walk in now, you see artwork and murals on our walls, right? So those are the kinds of things. Ultimately, it's almost like a feeling that you would get from the role of the designer. It's like a feeling you get when you walk into the place. And it should be a good feeling and a health feeling. And I've been thinking a lot lately about, I think what they call the hierarchy of needs, right? And the first one is kind of the physical things we're talking about, shelter, place, right? The next one, up from that is kind of safety and security, which includes healthcare, and it goes on to having a job, to being able to be belonging and feeling included in your community. And then I think the top of it is self-actualization, right? And to think that, from lower down, maybe in that hierarchy at the start, that's where interior designers are often engaged with us.
And, some of the activities we've been involved with specifically for access, thinking along the same lines as Fabio and Peter, and it really starts to get towards the drivers or the social determinants of health is to some degree we're trying to bring healthcare to where the need is. And Ave, you mentioned our COVID environment, right? So we dispersed into the community with pop-up tents and taking advantage of faith-based locations, since no one was going to temple or church or mosque anymore. So we would go and set up first for testing, and then when vaccinations became available, also to vaccinate people. And we're still setting up pop-up areas around the footprint of where we're at, really the greater New York metropolitan area. But we're, more constructively, or more of an infrastructure component, is looking at how do we really place then long-term clinics or just healthcare sites in the communities where they need them. And we're doing this in a very evolutionary way. It takes a little bit of time, which is, we're usually much more quick in our actions, but between having to work through real estate and related items, it takes a little bit, but we're incredibly focused on putting clinics in underserved areas so that we can overcome those social determinants of health. We're currently moving one from really an area that does need it, but to a little bit further down the road where really centrally people who are underserved, uninsured, underinsured, immigrants who are afraid of identifying themselves because they're afraid of us contacting INS, which is not part of our shtick. So we move to them to build the trust, and we go out into the community to build the trust, to really connect with them. LGBTQ clinics that we open up in Manhattan, along with HIV clinics as well, bringing it to where the need really is, and really establishing at all of our locations that we really practice diversity and inclusion, right, and health literacy, that we really try to overcome the disparity and inequities by training our teams, publishing literature, and welcoming everyone to our facilities and asking them how they prefer to be referred to, which pronoun, if any, do you want to be referred to as. So it's a lot of sort of common sense, bring it to them, and then how we welcome everyone as well to make sure that access is readily available. And we're really focused on doing all those things and getting the care to where it needs to be. We're partnering with our mass transit folks as well, especially bus lines, to make sure those bus lines can capture people that need to get to some of our sites as well, if it's still a little bit far away. We're partnering with a company called Ambulance. It ends with a Z, not an NCE, to help us with some of our non-emergency transports as well. So there's several solutions out there to help us really raise the health of everyone in our community. And we're reaching out to them from a direct health, but also, not to get too far off target, and I won't take it too much further, but from a corporate social responsibility in terms of air quality, water quality, and not just the basic, prevention measures like don't smoke, don't drink, healthy diet, but really involved with the environment overall to make sure everything they access is truly, truly healthy. So we're really focused on a lot of that as well.
So I think designers are uniquely trained and positioned to deal with these kind of messy, comprehensive social problems, right? Like we're trained as specialists. We can talk technical all day long, but we also have this way of kind of thinking big picture and seeing all of the sum of the parts and kind of understanding the holistic situation. And I think we need to leverage that more as a profession and kind of work more with multidisciplinary partners, as Peter and Dan were alluding to. I think we pretend to be able to save the world, but we can't do it alone. And I think in my own experience, in my own practice, the most innovative, most creative solutions have emerged, from myself and my team when we partner with other individuals that are unexpected sort of individual partnerships, right? So, and I think that in this healthcare situation, right, or the issues of healthcare access, partnering, as I said, with IT and communication infrastructure firms, right, that start to talk about big data, but then also talk about new ways that we can leverage technology, right? Even partnering with, cultural and community groups or K through 12 education experts, and bringing STEM education into the community that starts to bring the idea of healthy living practices into our basic education infrastructure, right? I mean, I find myself sitting there designing curricula as part of the delivery of a project in some of my projects, right? So it's kind of crazy, but we have to kind of flex our design muscles in ways that we typically are, don't, right? We're used to just doing urban design, urban proposals, buildings, if it's industrial design, then products, if it's interiors, then interiors. I think that there's a lot of magic that can happen when we start to think, hey, I can think about my design skills in the design of, a K through 12 curriculum and what that might mean in relationship to social inequities and, and physical space, right? So, I think also on the urban scale, Randy was starting to talk about air quality and water quality and things like that. I think there's also a lot of potential in, sort of designers working hand in hand with healthcare system providers, in partnership with developers and agencies to address perhaps a new level of preventive care, right? So we talk about preventive care as going to your annual physical, having a PCP, having access to shots and vaccinations and so on. But what about preventive care in relationship to the urban environment and the sort of social determinants of health that are actually impacting the community, right? So we all know that there are communities at risk, in terms of not only quality of life, but life expectancy, risk of obesity, asthma, mental health, chronic disease. And what's affecting the conditions, these conditions are exacerbated by the physical environmental conditions in which these folks live, right? So garbage and trash, on public sidewalks and public space, lack of public space, lack of green, causing heat island effects, right? Where, all of the architecture and design community know about, the need for affordable and healthy food options, right? Adequate housing. And so these are things that, what if there could be some magic that pairs healthcare systems in partnership with developers and planners in sort of unexpected ways to create a new level of preventive care, and I think that in these sort of unexpected multidisciplinary partnerships, that's where a lot of solution building can be had. So.
I think in every case that you all have spoken to, there's the level at which maybe architecture or design operates at a tangible and physical scale, but then there's this potentially much larger, and Daniel alluded to that in his opening remarks as well. There's this potentially much larger sort of role for designers and architects to play in improving access. And Peter, you called it, you use the hierarchy of needs, talking about sort of emotional or cultural needs. Fabio, you spoke about sort of, but even the sort of tangible design elements, how does equipment get in and around an apartment? In it contains the questions about what apartments are like, and who are these patients, what kinds of apartments do they live in? And I'm sure your team went through all of that. And Farzana, what you were talking about, just in terms of really understanding those sort of that deeper power that we have as designers to address those bigger questions. That's kind of where some of the magic lies for design. And to that last point, especially around some of those social determinants of health, we're understanding more and more how some of the progress that the design community has made around the green building movement has translated into a healthy building movement, and there's so much sort of talk around that. I'm reminded of Enterprise Green Communities, if anybody is familiar with that, and the work they've done in certifying affordable housing, but really using health as a major kind of framework for certifying developments as being sustainable, right? And so there's a way in which that there's an aspect of resilience here that's built into how we think about design as well. I have one or two questions here from our audience. I'll take those real quick. Anosha Zanjani says, have your systems thought about using telehealth kiosks to provide access, typically for people who don't have access to appropriate broadband to even access telehealth? I'll let one of you respond to the specific question about, bringing telehealth to people who might not have broadband access. So even when we assume, telemedicine is sort of this silver bullet for getting healthcare to everyone, as Fabio, and I'm sure everybody else who's implemented a deeper telemedicine plan this year knows, that's not always the final solution. So I'll let you respond at that. I'll let all of you respond at that level. But I'd love to talk a little bit about new models, like Peter, your neighborhood care program, but new models for where you've pushed forward on access or mobility in some way in projects. So if you can think about that too, just give us an example, or even something you're considering at this point, or Daniel, something that's conceptual and still on the, on the drawing boards, maybe, in terms of how do we address access, in our projects. But first, let's talk about, I'd love to have someone address quickly the question about telehealth kiosks or bringing telehealth to people.
I could share a couple of thoughts on it. All of our physical buildings, right? As much as we brought in, space for neighborhood care, we brought in, space in a very basic way to conduct more and more telehealth visits. So we built those rooms, right? Part of us, we want to meet you where you are, and if you can't get to us, well, we're still there, and you can still, communicate with us with telehealth. One of our partners, City Block, I found talking to one of their founders, very fascinating. We created some space for them. Again, it wasn't medical office space, but it was space where they have a group of people who really are supposed to spend their time walking around the neighborhoods around our buildings and going to people's homes and going into their homes and meeting them there. All right. And then that brought up a whole nother conversation, well, what's that like? And the founder said something that always struck me, that some of these people that are home, when they come into the doctor office, they feel uncomfortable just in the office environment, but that when somebody from City Block comes into their home and sits with them in their home and speaks to them, they feel like they're getting a visitor from, like, a child or a cousin or a neighbor, and there's like a closeness. And then it brought up another conversation, which goes again to access and this idea of a kiosk. So the City Block people don't exactly have a kiosk, although I love that idea. Like, you can walk around the city now and you see these places to plug in and charge your cell phone, right? But the City Block people actually, bring their phones and small devices, and they're actually kind of, bringing that into these homes where people don't have devices of their own. And then I even started thinking that maybe we should just, ask, do you have a router in your home? Oh, you don't have a router in your home? Well, along with giving you, if you need a walker or a cane or something else, hey, here's a router. We'll install it for you. But I don't think we've gone that far yet.
Yeah,
And the kiosk idea is great. We should put them outside our offices. So when we're not open, right, it's almost like you can go up to the ATM and hit the kiosk. I'm gonna think about whoever asked that question. That's a real good, thought-provoking question.
Yeah, and on that front, I mean, there's a basic idea here around the kiosk as something that can that can be placed somewhere. But to Peter's point, something just like the kiosk can be literally brought to the patient, and we have developed a program here at New Lab, actually in conjunction with support of Verizon, to bring our own little 5G modem and connect to a high-speed throughway, and actually not only have a kiosk, but a super connected kiosk, if you will, that can enable advanced form of teleguidance and connect those devices to cloud-based system that they make them smarter. So it is something that I think it goes against the idea of the difficulty of patient of having good internet. I think it's relatively straightforward for us to bring this internet, not only internet, but internet that's secure, fast, and reliable.
Can I just jump in real quick? So I know this is the question, I think, on telemed is more positioned to the health systems, maybe Peter and Randy. But what is interesting to me is, and I think I had this conversation with the panelists the other day, is that the pandemic we had, if we didn't have Wi-Fi or internet, I think the economic and health and every other social order would have collapsed, right? Actually, we were all able to escape. And when we look at something like that, right, the internet should almost be looked at like as health, right? So we should have these accessibilities. So we're in a world now, the internet is literally the greatest library ever created by man and a resource. And I wonder why we are not talking to politicians and or city councils and so forth to say the internet or Wi-Fi should be almost as readily available for these social reasons as water, electric, and gas and so forth. And there are very good reasons. And we can see in third world countries, in fact, communities and societies are starting to surround themselves to almost these internet poles, you know, the cell towers and so forth, which is kind of weird, right? It's become the campfire, and it's not supposed to be there. It was supposed to be of old days. It's supposed to be socially out there. But the question about the pods and so forth could be a great answer to. I like how, Peter, you had said there's these kiosks now in Manhattan that you power up your phone, and actually I see people camped out around these, right? So all they're doing is watching their Netflix or whatever. But if you actually change that to be a pod for telehealth or something, and truthfully, we all need somebody to talk to at any time, right? It doesn't need to be a scheduled time. So sorry I jumped in there, Fabio, and so forth on you.
So Peter, Dan, and Fabio, to your point of having a need for a kiosk, I've got one designed, so we can talk about offline. But that's exactly
it's being shipped in right now, Peter.
There's my plug, right? No, but essentially that's the micro infrastructure sort of module that we are rolling out in Puerto Rico, in parts of Latin America, in parts of Asia, on a very low tech level. Now, so, you know, having station types that are off the grid, that, you know, can work in times of crisis as well, right? So I think it's important to understand healthcare access in times of a storm, when, you know, electricity is down and drinking water is not available. And so what do you do? And so, and you know, I'm talking about that in the context of other places, but we're starting to see that more and more in New York, right? You know, when we had Ida come barreling through, right, and Sandy previously. And so, you know, it's not something that we shouldn't be thinking about even in New York. But those sort of kiosks, right, they become exactly what you're saying. They become sort of public landmarks and public sort of gathering points, right? They're reliable places where people know that there's a level of trust in those kiosks, and oftentimes if you engage community in the building or the design of those kiosks, there's even more trust. But they essentially become places that are go-to from the public to access all sorts of types of infrastructure, right? Whether it's water, energy, healthcare, medicine, you know, your vaccination shot, et cetera. And we're seeing that already. and really great results in other places. So why not New York?
Yeah, absolutely. Yeah, in a way, the pandemic has been a great equalizer, right? And so it has really exposed some of the ways in which there are patterns of inequity around the world. I think there's no exceptionalism to New York or really any place else. I have a direct question here for Peter from Franklin Rose. So I'm going to ask it as it's been asked, but then as usual, I think I have a follow-up, more general question for both Peter and Randy. Franklin Rose says for Peter, is Emblem Health in growth mode in terms of real estate acquisition for internal corporate operations or ambulatory care services at this time? So are you expanding?
We have been expanding. We had a footprint that was very traditional that went back, I think, to the 40s when the mayor of New York wanted to sort of self-insure instead of having to buy insurance, from the insurance business that was developing. And there was this concept that there should be a medical office in every neighborhood where everybody lived. And so we covered a lot of them. I think we had, when I got here, we had like 30 some buildings, and we kept those 30. And we then in 2018, we added 3 offices along a little belt in the Bronx, 149th Street, Hunts Point, and Parkchester. There's a little bit of an area where, the big system up there, for whatever reasons, was just a little north of there. So we did open 3, and they were each about, they were like 10,000. So it had primary, small peds, and some specialties, but obviously we couldn't, have all of them. And then we also then on Staten Island, where we always had 2, one on the north, one on the south, we saw development moving towards, the real far end of Staten Island, around the Staten Island Mall and Richmond Avenue. And there was a lot of talk about trying to get into kind of healthcare should be retail, and there's opportunities, because all these retail spaces. So we went in to a new part of the mall, right, where we're next to like a beauty supply company and right across the street from Shake Shack, right? So that was an expansion. And then we opened a new site in Jackson Heights, which we're really excited about because that is a very diverse community. We had not been there. We would have told you we're only 5 miles away. You could go to Elmhurst, or you could go to Forest Hills, or you could go to Flushing. So why would we, some people said, well, why do you want to build so close when you have other ones, right? And we go, we think we want to expand. We can reach, more people by meeting them where they are. And that was an interesting, building too, when you talk about zoning, right? The developer had put up a building that had one of these mini Targets, food services, Starbucks, some of the other ones you would expect. Second floor, zoned for community health care use. And people thought a little bit funny about expanding, in a building that's commercial below. You're going to have food odors and traffic and deliveries. But yes, we're expanding. Then at one point we started trying to count. Well, can we go to 45? Can we go to 50? And I think the leadership's mind is still open. Yes, we can expand more.
That's wonderful. Jumping off of that, Randy and Peter, certainly, in the commercial real estate world, when we're talking about workplace, or if you're talking about, schools and education facilities, there's been a lot of thinking and rethinking about sort of what are the broader models for how those facilities are distributed in cities. So, now we're talking about hub and spoke. And even before the pandemic, there was this whole kind of, co-working revolution and stuff like that. Certainly there was a wave of new manufacturing or industry 4.0 that where Fabio is sitting, New Ink is kind of part of the new lab is kind of part of that wave in New York City. there's been a lot of churn. In healthcare, I know there's been a lot of, talk about, well, what is the model in terms of, is it the hub of the big healthcare facilities and the neighborhood clinics? Is it something else? Just how have you been thinking about just the pattern of your development or growth in terms of bringing healthcare to where people need it, but also thinking about where it is possible for you to put in the infrastructure and the sort of the standard of care that you would need? I mean, you can't do everything in a neighborhood clinic, and so, how are you thinking about the balance between those things?
I think Randy's got to talk to that first.
Right. So thanks, Peter. So, and let me I wanted to add one other comment to the telemedicine kiosk. We're exploring different ways of leveraging that technology, but currently today, what's very active, we do home visits, right? So we have paramedics doing home visits, medical students from our Hofstra School of Medicine, homebound visits. We take the lab out to home visits as well. We have LabFly, which is an excellent product to really help, again, searching for ways to overcome access issues. And then for the most recent question, Avi, and everyone, part of it falls back on my previous answer about bringing things into the community, but so much of what we do really is ambulatory based, just for those reasons. I think eventually hospitals will be really dinosaurs, right? It'll be major birthing centers, very complex surgical centers, and incredibly critical care, super ICU locations of care, where so much will be taken care of in these ambulatory surgery centers sprinkled around the landscape and in the communities, primary care locations. You read the newspapers, right? CVS, Walmart, Amazon, all getting into the action and really enhancing access to care. And we've been partnering as well with some of those players to really be able to add value to providing better access to care out there. Because so much is in that ambulatory arena, such that it's possible in the not too distant future, someone who's rushed to the emergency department and they're very ill, after they get stabilized, might get sent right back home. But before they get home, the hospital bed company will beat them there and deliver the hospital bed. The physician and nurse will go out and set up that type of telemedicine that you're talking about, ensuring all of the proper connectivity to monitor the physio signals of that patient, and then continue that monitoring over telemedicine. So again, we're going to be migrating sort of away from the traditional hospital today into, or what we envision, just units and units of patients versus birthing centers, super surgical centers, and truly the sick of the sick, critical care patients being in there, and building the rest out there. So we're very focused on meeting the ambulatory needs of our communities, right? All over Long Island and through the 5 boroughs of the city, and expanding a little bit further into New York as well.
If I may just follow up with Randy and Peter, it's just a question, that's come to mind as I've worked with communities. A lot of the problem with healthcare access is a level of anonymity. In other words, we don't have the small town mentality in New York of everyone going to the same doctor, right? I mean, there's not the one PCP in the zip code that everyone knows and is familiar with, and there's a level of trust and comfort because your neighbor goes to the same doctor, right? And so I don't know. I mean, it's a question. Is there a way to kind of leverage sort of a face to the neighborhood care center, Peter, that you're talking about, that becomes the face of that zip code, right? That people know to go to ask questions for a neighborhood care coordinator, I don't know, or Randy with these home visits, it's probably messy with insurances and everything else, but how can there be sort of this 5-block radius, this is the care team that always gets deployed to that, area. Maybe this was already happening, but I think that a lot of it is word of mouth and trust. And so it's just an open question.
Randy, you're on mute.
Thank you, Avi. And the sign came up at the same time. So our population health team is making strides towards that as well, just to sort of get that small town comfort while maintaining HIPAA compliance at all times, and really super dedicated to reaching out into the communities and doing that type of care as well. So they know the faces, right? Even as big a footprint as we have, it really isn't that big at the end of the day, right? It's a small world and getting smaller through technology. So absolutely, we don't have all those answers yet, but we have some smart people working on those, Farzana.
I like that question from a designer, right? And we're talking a little bit from, a community of designers. Designers sometimes have, ways of imagining things, right? So I thought it was a really imaginative question. You started out with the question, do we have hub and spoke? Yes, we have it. It's been a tradition. We have that. So my question would actually go back to Farzana or any other designers who are listening. How would we achieve what Farzana is asking? We're opening the neighborhood cares. We're opening more of them. We're accessible. You can find us, right around the corner. You already know where Starbucks is. Now you know we're next to Starbucks. But the idea of a face, that's kind of a whole nother. I think I would ask a designer, how are you going to help us imagine what that would be like?
The first answer to me is, a combination of outreach on the ground, and then also a combination of leveraging social media. So, and I know that that's kind of counter it's almost anonymous to be on social media, but, I think social media connects people into networks, right? For better or worse, for better or good, or not good, not so good. But I think that, there are community networks already that exist, and to kind of tap into them and offer that face into the mix, maybe a starting point.
Yeah, the community outreach. I think we all dive into projects independently without like what I was saying before, just take a step back. Randy, you used the word before, it was just said common sense. And we tend to take our professional job, and I know the rules of steps, and we get lost. We take a step back and you go to whether it's faith-based operations or whatever the community is really believing in to help as a voice to that. Again, whether it is an outreach program, it doesn't have to be faith-based or such. It is a huge entity. I want to take just a spin on that, Peter. I love it. So HDR had an opportunity to have a question like that come to us about the tri-state area, and they said, "What could you best do to help the health systems and so forth?" And I said, "In truth, get designers and architects and engineers to be educated in this aspect before they even leave college." And we actually had helped put together an accredited New York Institute of Technology with a master's in architecture of health and design from HDR, to the point of we need individuals to be thinking of that before leaving, and all of these other aspects. And if you want, we could put some of these questions into think tanks on thesis students who could probably spend a whole year of coming out with the greatest free labor. Let's not say that out loud, but there are real answers there. And that generation has social aspects of social media and connectivity to communication that is just really, we've never seen anything like this in the advent of humankind in history. So communication is key. and to listen and then just not to float above and say we're just dropping in something here. Be part of the communities. So
yeah. Well, we're right about at our time today, and in response to what you said, Dan, I think I will say that there's never been a more exciting time to be in designing for health. And so for anybody who's interested in doing that, I mean, we are surrounded by conversations around health now, for better or for worse. And we are, I think, have asked so many of the right questions today in terms of access and equity and mobility and the experience of communities. And we've looked at so many exciting new models, including Ponto Care's own model, but so many others. For example, you've brought up a few. We have the kiosk questions. There's just so many ways, so many tools in our arsenal, and we have to imagine others yet, as Daniel, you just said. So there's so much to be done, and this is one of the most exciting challenges we have, especially in this country where healthcare isn't always intuitive or easy to some communities. So thank you all so much for joining me today. I really appreciate it. Thank you also to our sponsors, Arcom, Arden Studio, Growy, Alex Houses, and Versteel for supporting today's event. Thank you to HDR for hosting us and for putting this power panel together.
Yes.
Thanks to everyone in the audience for listening to us today. Think Tank Thursdays will be back next week with a conversation about how we can design for both productivity and equity in the workplace, talking about different tools that we can put in place for equitable work. So I do hope you'll join us for that next Thursday, same time at 4 p.m. Eastern time. Thanks everyone again for joining us, and I hope you have a great evening.
Let's talk about the germophobic elephant in the room. For the last year and a half, 2 years, whatever, I don't even know anymore, we've been locked indoors. And really, I see this as an opportunity to rethink what should normal be? How should we redefine normal? What should it look like? I started a podcast with my friend Eve on the intersection of care and healthcare and design, called Care by Design, that's true. And then I wrote a book. This is book number 12. What else are you gonna do in a pandemic except write? And the reason I wrote about the circular economy was because I really see it as the framework we need for the challenges that are facing us. If the traditional way we make stuff is take, make, waste, right? We harvest stuff at great environmental cost. We then essentially slowly turn it into trash. The circular economy proposes an alternative to that. Really, instead of take, make, waste, it's harvest, make, and remake over and over and over again. And companies like Adidas and IKEA and Intel and Amazon and Patagonia have all embraced the circular economy, so that's why I wanted to write the book about it. So with all this kind of swirling in my head, the question becomes, now that we're coming out of our little cave here, where do we go from here? So what I want to talk to you about very quickly is three things. First, I want to talk to you about just the urgency of how to teach this. So as students and as teachers, how you can talk about really climate change without bumming everybody out. Number two, that we need to redefine how we talk about the cost of these things, because we're still kind of locked in that 1980s mindset of green buildings cost more. No, they don't. And then third, I want to talk to you about how we approach this as an innovation strategy. So that way you can start to see how to apply it to your own projects and also how you can teach this in studios. And I want to start with just the urgency of it, because you have to kind of set the context here. What I've realized is that a building is not just a building. And we can't think of it that way. A building is actually interconnected to a whole network of infrastructure and legacy systems and communities and neighborhoods and people. And to try to solve the world one building at a time is going to be a problem. So we need to almost take a district scale approach to every project. Even if you're just doing a tenant improvement build out, it's part of a community. and there's legacy systems there. And all of these are opportunities for us to do more. The other part of it is that a lot of the assumptions that we put into our buildings are no longer true. And in fact, they might never have been. We're designing, hospitals in Miami Beach, and we're not designing the air conditioning system for today, we're designing them for 2050. Because it's just gonna get hotter and stickier and wetter there, right? And at the same time all this is going on, we are building a lot of stuff. We're gonna double the world's building stock by 2060. That's the equivalent of building an area the size of New York City every 5 weeks for 40 years. China is consuming all the world's natural resources. They're building 50 bridges a year. They're building a dam a day every day since 1949. They use more concrete in 2 years than we used in all of the 20th century here in the US. It's just an unprecedented amount of stuff, and you can't even conceive it. And then here in this country, we consume a lot of stuff at an immense amount. In fact, we build 4 new dollar stores every single day. Last year, we crossed a very weird tipping point. For the first time in human history, there's now more man-made stuff than there is biomass on Earth. In other words, those old roller blades and all that crap that sits in your closet, there's more of that stuff on the planet than there is life. And that's never happened before. So we've hit kind of peak stuff, essentially. And it explains why the richest guy on Earth is the guy that sells us all this stuff, right? That kind of tracks pretty well. So that's why I'm interested in the circular economy, because it could potentially fix that. Because whether it's take, whether it's make, or whether it's waste, all those areas make Kanye happy. You know what I'm saying? Like, they're all bad, essentially. You can laugh at that, it's okay, it's fine. And yet, this is going on before most of you were born. Every president since JFK has been briefed on the risk of climate change. And what's even worse is that more than half of the carbon that we've released has been since 1990. So we've done way more damage knowingly than we ever did in our ignorance. So this is now where we are. The decisions we make in the next 18 months are going to determine the entire next century. So we can either have a hard couple of years and do the work, or we can really suffer for the next century. That's what it's come down to. And that's kind of the problem. Jim Collins has a book called Good to Great. And at the end of the book, he writes that he does this challenge to CEOs. And I want to give you the same challenge. In it, he asks them to write down their 5 most brutal facts facing them. And so I did this for the design industry. The 5 most brutal facts facing us, as I see it, and you can disagree, number 1 is that climate change is going to change everything. It's going to put a price on carbon, and that's going to change how we design our buildings, how we track them, how we measure them, and what our modicum of success has to look like. Number 2, liability is going to make whole areas uninsurable. And by areas, I mean geographic regions, but also whole industries uninsurable. They just won't be able to exist anymore. And we're already having those conversations with insurance companies right now. Number 3, we use a lot of concrete in our buildings, and we still don't have a low carbon alternative to concrete, and we need one desperately. Number 4 most brutal fact is that the sheer demand for materials worldwide means we can't keep consuming natural resources. We're going to have to grow building materials. We're going to have to use engineered living materials. Whether you like it or not, whether you're grossed out by it or not, it's going to have to happen. And finally, the 5th most brutal fact is that we're going to have to deploy technology in a way that we in the design industry have never really done before. And we don't really know how to do that well yet. Every other industry is doing it, and we're going to need to do it too in order to speed and scale to the level that we need. And those I see as our 5 most brutal facts. And like I said, you're welcome to argue them with me afterwards over drinks if you like. Okay, so that really leaves us with 6 things I think you all need to do right away for all of your projects, either studio or in the real world. Number 1, you have to make it as efficient as possible. Number 2, you have to target net zero on every single project. Number 3, you have to use every tool in your toolbox, and I'm going to show you a bunch of them today. Number 4, we need to measure everything measurable, and I'll show you a little bit of that. Number 5, we need to do it now. You can't wait till you're comfortable or you're happy or you're confident, like get over yourself. We need to do it all now. And then finally, number 6, we need to use nature as a technology. Bioremediation, phycoremediation, passive solar, passive ventilation, thermal mass, all those things nature gives us for free, we need to now deploy at scale. And we need to look at technology in a new way, because we're not really getting the data or the insights that other industries do all the time. We're still dabbling with prefabrication and automation, and we could be scaling those up really. So what we need is, for lack of a better word, an extreme makeover carbon edition, if you're into that kind of thing. We need to get to zero by 2050. The thing I struggle with as an architect on a daily basis is anytime we demolish a building, anytime we build a dumb concrete glass box, or anytime we don't target net zero, anytime we do these things, and believe me, we're guilty of it all the time, just like everybody else, but anytime we do these things, that is a form of climate denial. We're denying the reality that's facing us, really. And I struggle with this. And I imagine you do as well. Because this is hard to accept. You can't keep going on one more building. It doesn't work for me anymore. The one thing that gives me hope, and I find I'm more hopeful now in my old age than I ever was when I was younger. The one thing that gives me hope is I think about this all the time. We destroyed the planet's climate by accident. We didn't mean to do it. We weren't trying to do it. We just did, oopsie, we did it. And what gives me hope is, imagine what we could do if we tried. Imagine if we put our minds to it, what the kind of things we could accomplish. That, believe it or not, that makes me feel better. And hopefully it does you too, because otherwise this is a pretty, depressing talk. Okay, so number 2 is looking at cost. I still have my students come in with that assumption, green buildings cost more. They state it as a fact. And I say, what evidence do you have to back that up? Because they don't really. I'm starting to suspect it's not really about the money in buildings. We're building $1.6 billion stadiums that are used 8 times a year to watch a bunch of millionaires play a game by people who are spending money that they can't really afford. So I don't think it's about the money. That chasing of money is a trap, and we can't fall into it anymore. We've been doing it for 30 years. The truth is that a green building is a better building. You need to get that into your mindset. You need to bake that into your projects. Stop this altruistic, gosh, is it okay if I don't put cancer-causing chemicals in the cancer center? Stop it. We need to do it because it's the right thing to do. If we do our job correctly, sustainability doesn't cost you money, it makes you money. If we do our jobs correctly, we can save $10 trillion by the end of the century and save ourselves in the process, just by keeping heating below 2 degrees centigrade. So everybody wins. Think about the normal healthcare institution, right? With its long waits, its low comfort, its high stress environment, everybody there's freaked out. Think about the typical education environment, right? Just bad design, bad lighting, waste everywhere. Think about the typical office environment we've become used to. Bad light, bad air, bad connection to our coworkers. If we start to measure these things and place value on them and show the outcome of this, if we start to measure these things, we could potentially change the world. So that's what I've been doing with my students. I've been asking them to measure things that were previously unmeasurable. Because how do we normally measure success in a building? I don't know, cost per square foot, maybe it's payback, maybe it's ROI, right? But how could we measure success in a building? Couldn't we also measure the recovery times of the patients? Couldn't we also measure the amount of stress that we reduce in their families? Couldn't we also measure the retention of the staff? All those things have value as well. So let's start measuring them. And how should we measure success in a building? Couldn't we also measure how much energy it consumes or produces? How much carbon it sequesters? How many species it provides habitat for? These things also have a value. So if we change what we measure, we can change the world. And the projects I'm going to show you were really all basically based around this very central idea of maybe we should change what we value and change what we measure, which leads to number 3, this innovation approach. Sustainability cannot be added on. It's not cinnamon that you sprinkle on it later. Like, it needs to be baked in from the start. One of the easiest things that I do it in my meetings with engineers and I do it with my students. We're sitting around and all they want to do is tell me what they think. And I said, don't tell me what you think, tell me what you wonder. Tell me about the possibilities. Tell me your big idea. And just that little agenda shift, don't tell me what you think, tell me what you wonder, changes the course of the conversation and moves it into one of possibility. Innovation is messy. It never looks the way you want it to look. And if you don't believe me, just remember that the inventor of the light bulb did it by candlelight. So I remind people of that just because innovation never works out the way you want it to look like, but yet it is a priority by virtually every CEO. They know they need to be innovative or they will fail to survive. They will not exist anymore. My childhood is filled with things that I loved, wonderful, innovative things that at some point stopped being innovative and then they went away. It turns out that businesses are not designed for innovation. They're really designed to maintain the status quo of existing models, right? They're really good at efficiency, but not for innovation. So you need to choose innovation. You can't wait for it. You can't wait for the client to come in. No client is going to come to you and say, hey, you just graduated. Here's a lot of money to go be innovative. That's not going to happen. You need to push it on them. You need to choose it. You need to make it a priority for them. Okay, with that being said, I just want to close with one last thing. I teach at BAC up in Boston, even though I live in Portland, Oregon. I don't understand it either. But I want to show you some of our grad students' projects and how we got there, more importantly. And there were 6 requirements that we do, and I would urge you to copy these 6 requirements. They come in at the beginning of the semester and they have no idea what they want to do. And I tell them, whatever you do, you have to be passionate about it, because this is going to be, it's a lot of work if you're not passionate about it. It's hard to fake that. Number 2, it has to be actionable. You can do whatever you want in your thesis, but I need you to make it real, right? You need to be clear on what to do. Number 3, it needs to be solutions-based. It can't be a book report about how bad things are. Nobody wants to read that, and besides, it's already been done. Number 4, it has to have an audience. You need to have a stakeholder involved, at least one, but the more you understand that audience, the more the problem will start to define itself. Number 5, you need to have a clear plan, and one of the appendices they all do at the back is essentially a marketing plan of how they're going to do this. And number 6, it needs to have a life after graduation. I want them all to potentially see this as a roadmap for their career. So I just want to show you very quickly what some of them have done. I've got a dozen of these. There's plenty more, but this was Jen. She came in saying, I'm interested in stormwater. I'm like, nobody's interested in stormwater. She's like, well, I am. Well, she drafted the stormwater policy and got it adopted by the city of Somerville, Massachusetts. She did that in a semester. This was Helena. She was bothered by construction waste. So she made a grading scale for materials so you could determine how to salvage and reuse them. This was Shalisa. She was a nurse, a 40-year retired nurse, and she went back to grad school. And so she redesigned new design standards for nursing stations that were patient-focused, that redesigned the layout of them. And it turns out nobody had been doing that before. This is Molly. She was bothered by food waste. That's what she came in saying. I hate food waste. I'm like, what do you hate about it? She said, well, it bothers me. I'm like, well, what are you going to do about it? And she mapped out the entire design statement and realized, you know what she could do? She could do a pop-up restaurant that uses ugly food, which we normally throw away. There's a whole thing of like Google ugly vegetables, and you'll see. And she started a campaign called Eat Ugly. And so celebrity chefs, pop-up restaurants in cool locations around Boston, serving food, and it raised money to feed the homeless. And she launched her first one the next semester after graduation. This was Krista. She was obsessed with homeless people. That sounds weird when I say it like that. She was bothered by the homeless people, so she got city-owned land that the city gave her. She took waste from the municipal waste, ground up part of it, put it into a 3D printer, and figured out a way to 3D print homeless shelters. And this was in a cold climate, by the way, so it was kind of amazing. And then this is the last, I think this is the last one. Natalie said, I love biophilia. She was known as the biophiliac, I think is what everybody called her. And I said, what do you love about biophilia? She said, I think every school should have biophilia in it. So she created design standards that combine the Safe Schools Protocol, SEPTED, which I don't know if you've looked up, with the biophilic design patterns, and made a whole new set of how to design green schools that are also healthy and safe from active shooter drills using biophilia instead of fences and walls. It's kind of amazing. And now she's doing that as a consultant. And then last one, this is the last one, I swear. Rania wanted to design affordable housing for refugees. She said, that's what I'm passionate about. I'm like, okay, isn't that already being done? And she looked into it and she said, actually, yeah. So what else can I do? I said, well, what needs to be done? And she realized the refugees were getting free housing. The trouble was they didn't know how to acclimate to the United States. So she created an infographic guide that has been translated into dozens of languages now called This Is Home. And here they are reading it. And it shows them what to do and what not to do so they can acclimate to weird American customs, like don't start fires in the middle of your living room, which was a thing that they were doing. It's kind of amazing. So there's a quick smattering. I'm probably way over time, as I warned you. But anyway, in the time that I've been talking, another 1.5 million tons of CO2 has been released. So this little challenge of ours isn't going to go away. So I'm urging all of you to rise up to the challenge. I'm hoping this has opened your eyes to some of the possibilities. And if you could start to do this and embrace this way of thinking in your projects and in your real world, well, wouldn't that be the, I don't know, pot of gold at the end of the rainbow? And wouldn't that make everybody happier?